This conference will
So, Bismillah ar-Rahman ar-Rahim. We'll discuss today an article published in January 2019 in the TOG. It's about the surgical causes of acute abdominal pain in pregnancy. It's a very informative article and very useful for both surgeons and obstetricians, really. In the introduction of this article is the abdominal pain, acute abdominal pain in pregnancy is common, it's not uncommon. Differential diagnosis, as always, it's obstetric, surgical, or medical causes, and surgical here is urological and general surgical both. And even in any women, anyway, we know that any woman in childbearing period comes to us to the general surgery with acute abdominal pain, we always consider obstetric cause and medical cause of their acute abdominal pain, really. So these are the conditions that can cause acute abdominal pain. It's atypical. Usually the presentation is atypical, which is not good, and it put us in a lot of dilemmas actually, and makes the assessment and management difficult. And the dangerous thing is it delay the diagnosis and worsen the prognosis, unfortunately. The conditions discussed in this article are acute appendicitis, cholecystitis, and biliary colics, bowel obstruction, ureteric obstruction, and bionephritis, pancreatitis, and the aneurysm rupture, which is commonly visceral aneurysm rupture, most commonly splenic artery aneurysm rupture, which is rare but very serious and fatal. And by the way, it's common in exam questions as well. Management of surgical condition, surgical pathologies in pregnancies. It will help you to do a continuous evaluation. So instead of seeing patients, for example, once a day, these patients needs to be seen twice a day, for example, in the morning round, in the afternoon as well. And sometimes we just perform some potential modification to their management. It should be collaborative and multidisciplinary practice. So it's not only the obstetrician manage these cases, surgeons should be involved, sometimes urologists, early involvement of anesthetists, and even the neonatologists and intensivists should be involved early if we think they are really needed. So we should really involve all these specialties early in the beginning. Incidence, I know in exams they like a lot numbers. So the incidence 1 in 500, 600, the incidence of acute abdominal pain. As I mentioned, senior surgical input should be sought. And the UK senior surgeon means usually a consultant or a registrar. And this should be done very early because it's useful to consult a surgeon early because it will modify your management of the case, really. As the like numbers, 3 maternal deaths per year in the UK attributed to intra-abdominal pathology, unfortunately. So basically, we need to prevent those. Differential diagnosis. You will be very aware as a obstetrician of these, and we are very aware of these as well as surgeons. Non-obstructive causes of acute abdominal pain, appendicitis, biliary colic or cholecystitis, pancreatitis, peptic ulcer disease, bowel obstruction, ureteric obstruction, aneurysm rupture. We'll discuss all these in details. Non-surgical bionephritis, sometimes just it doesn't need surgical intervention. Inflammatory bowel disease sometimes needs surgery, but not common if they cause obstruction or perforation or something like that. Ovarian cyst, torsion, constipation, medical management, trauma and domestic violence is very important. We're not discussing trauma a lot in this article because it's not included in this article, but I will, give a hint in trauma in pregnancy while we're discussing the article. Psychogenic pneumonia. You need to bear in mind the pneumonia and MI and DKA, these three things, you need to consider them with any acute abdominal pain. I really myself think about them from the surgical point of view. When any patient referred to me with acute abdominal pain, I have to exclude pneumonia, MI, and DKA. So random blood sugar is very important. ECG is very important in in some categories of patients, not all the patients. So we have a male, young, he doesn't need ECG, but usually elderly males will need ECG, or someone over 50-year-old, and pregnant ladies as well will need ECG. We'll discuss this later. And pneumonia is a very important cause as well of upper abdominal pain and should be excluded. MI is a cause of upper abdominal pain, especially inferior MI. Pneumonia as well as a cause of upper abdominal pain, and I've seen cases referred to me as cholecystitis with right upper quadrant pain, and just they have lower lobe right-sided pneumonia basically. So this is the cause of acute abdominal pain, and these are the causes from acute abdominal pain in late pregnancy. That's not going to be covered in this article. Causes of mortality, as you can see here, if I follow these numbers, splenic artery aneurysm from 2013 to 2017, 9 cases. That's a lot, isn't it? That's a lot of cases. Mortality from a splenic artery aneurysm. This is scary, and I believe I've seen probably a case or 2 cases of those, and unfortunately they passed away. It is a serious thing, and we'll discuss it at the end of this presentation. Other aneurysms, like celiac arteries, are rare. They're rarer than this. Splenic artery aneurysm is very known in pregnancy. Pancreatitis can happen. Sometimes it can cause death. Here, it can cause late death. And sun obstruction, you can, if you notice that it's not common, especially in the last few years. Peritonitis, including appendicitis. Crohn's, one of the IBDs, can cause death. Duodenal ulceration, liver rupture, pseudomembranous colitis can. One case reported, and ruptured esophagus can happen. When someone have a severe attack of vomiting or something, it can cause rupture esophagus. They call it Boerhaave syndrome, and it is a serious condition and can cause death really. And pseudomembranous colitis, the Clostridium difficile that can come from inappropriate use or excess use of antibiotics. So what can we do for these cases? History. How can we take history? We need to bear in mind some red flag signs like readmission, multiple admissions, repeated doses of opiates. Usually we don't discharge patients who required opiates to alleviate their pain. If a patient required morphine or something like that to control the pain, we don't discharge these patients. But these are the red flag signs that require a senior clinician to evaluate, which is usually a registrar or consultant from obstetric team or from the surgical team. The onset of anxiety or confusion. You might be aware about the new definitions of sepsis and the Q-SOFA criteria. Confusion is one of the criteria that can be one of 3 criterions actually in the Q-SOFA. We can diagnose sepsis with it. So anxiety and confusion is very important. Anxiety might be a sign of hypovolemia. Confusion might be a sign of sepsis. We don't attribute them to a psychiatric cause. I think we've all seen. I've seen cases before attributed to psychiatric cause, and by the end of the day, they have sepsis or bleeding. Actually, it's not just an anxiety and confusion. Sometimes it's you know it's difficult to assess really. In the history, as you do with any patient, clerking the patient, when you take history here in the UK, they call it clerking. When you clerk a patient, you evaluate the present symptoms, assess the obstetric, medical, surgical, and family history as usual. Sometimes it is something specific like Marfan syndrome. It's associated with aneurysms, and, different varieties actually of aneurysms can be associated with Marfan syndrome. And don't forget to ask about trauma and any abdominal pain actually because of the domestic violence issues. How to analyze the pain? It's about the site and radiation, the quality and duration, exacerbating factors and relieving factor and associated symptoms. These are the ways of assessment of pain anyway, in any case. About the site, this is, you'll find a lot of images like this on Google or whatever, describing the sites of pain and what are the potential diagnosis of the cause of this pain actually. So you might notice the right upper quadrant is very famous of gallstones and gallstone issues mainly. And the right lower quadrant is very famous with acute appendicitis. And in pregnancy, when the gravid uterus is big, sometimes it can push the appendix up, and the acute appendicitis can present with right upper quadrant pain in late pregnancy. Kidney stones usually and urine infection comes in the flanks, both flanks. The verticular disease is basically very similar to acute appendicitis, but it is in the left side. And it's not common to present on the right side, but sometimes the verticular disease present with acute abdominal pain in the right side, especially in cases of redundant long sigmoid colon with diverticular disease. Sometimes if there is any diverticulum or something perforated or inflamed and a long redundant sigmoid, it can come on the right side, but that's not our our discussion now. Appendicitis can sometimes it's pelvic, so sometimes it comes suprapubic, but suprapubic is typical with pelvic pain, gynae issues, or cystitis or something urological. It's basically about anatomical site of the organ basically. Okay. But the issue here in pregnant lady is the right upper quadrant. Is it gallstones or cholecystitis or appendicitis? That's the confusing pit. And in epigastric pain, we should always consider pancreatitis. So we should always request amylase. That's really important. We should always consider pneumonia in the upper part of the abdomen, and we should all consider inferior Y, and that's why we request ECG, and we'll see that in the rest of the article. Site and radiation. So there are two types of pain, peritoneal pain and visceral pain. I will give you an example. Everybody knows that the appendicitis usually starts with periumbilical vague pain and then shift to the right lower quadrant or the right iliac fossa and becomes focal and sharp. And that's why, because it starts usually as a visceral pain, and then when the inflammation progresses, it causes peritoneal irritation. That then became peritoneal pain, comes focal and sharp. That's really typical thing with acute appendicitis. Start visceral and then becomes peritoneal irritation. And in general, for gut visceral structures present with upper abdominal pain, mid-gut, around umbilicus, hindgut, lower abdominal, mid-gut, appendix is in the mid-gut. It's from distal duodenum to mid-transverse colon, so the appendix is here, and that's why it starts with periumbilical pain and shifts to the right iliac fossa and becomes focal and sharp. Shoulder tip pain, it's not a common symptom, but they really like it in exams, and it's usually associated with diaphragmatic irritation. And diaphragm can be irritated by just blood, and that's why our colleagues, when they go to MRCS exam and FRCS exam, and they mention shoulder tip pain and things, we must consider ectopic pregnancy in this case, if it is in the exam. And sometimes it can happen from leakage or infection beneath the diaphragm with any cause, actually, maybe a ruptured DU or duodenal ulcer, maybe something like cholecystitis, something caused, subdiaphragmatic collection, or bleeding. So it's blood. You have to consider blood or visceral leakage in shoulder tip pain. Pain can be kulky, can be burning, can be stabbing, can be a lot of characteristics of the pain. Kulky pain usually associated with partial complete obstruction of a hollow viscus. So for example, if a stone obstructing the biliary tract or the neck of gallbladder, or some adhesion obstructing a lobe of bowel, so the pain would be described as a kulky. Patient can describe it as a spasms. The patient say have spasms, severe spasms, and that's how they describe it really. Burning pain, externally, probably it's a peptic ulcer or esophagogastric disease, like something like GORD, which is the gastroesophageal reflux disease, for example. If somebody has reflux, it can be described like this. Pancreatitis, usually burning pain, or refer to the back, or retrosternal pain. And in pancreatitis and upper abdominal pain, you have to consider, as I said before, the myocardial infarction. Although rare, but it must be considered. Constant pain is focal or generalized, indicate peritoneal inflammation. So if the pain is not coming and going, as we ask the patients usually, that's usually an indication of peritoneal irritation or inflammation, and that's usually something surgical. Sudden severe abdominal pain, this expression is not written in this article, but this just to highlight that sudden severe abdominal pain should always considered of a surgical pathology. So that's really important. Sometimes it's not clear, and the history is difficult, the examination is difficult, minimal signs, but it is sudden and severe abdominal pain. Please be careful. Keep this patient, keep an eye on these patients, ask for senior review. This is possibly something that might really need surgery. And pain usually change in site and character, as I described in the acute appendicitis. Starts kulky, starts periumbilical, and then shifts to the right iliac fossa and became localized and focal, and burning or just pain, as they describe. It's not kulky anymore, like acute appendicitis I described. Exacerbating and relieving factor. This is something from the experience, and it's written here actually. Patients who report visceral pains usually describe restlessness. There are two types of pain actually, or two types of patient you might see in surgery. One patient staying still in the couch or in the bed. The patient is not moving, okay, and the other type of patient rolling, in the bed and moving in the bed and things like this. So these are two different types of patients. So the patient who's not moving, usually that indicates some sort of peritoneal irritation. So this patient is guarding the inflammation and having a severe pain when she moves. But the other type of the pain, the patient roll in the bed, is usually something related to Kolke pain or something obstructing tubular structure like ureteric colics or biliary colic or at the beginning of bowel obstruction. So these patients usually, not serious, like the patients who are staying still, not moving in the bed. And in our history, you have to consider the other gastrointestinal and urinary symptoms. So seen here from really the time of the pain and from the analysis of the pain, site of the pain, the character of the pain, and the change in the pain, and even the lie of the patient in the bed, you can have some hints about the diagnosis. These are some clinical presentation of some surgical causes of acute abdominal pain. I'll just go through them very quickly. Ruptured or leaking aneurysm is very difficult, to be honest, to diagnose clinically. So nothing in this line. The most acute rupture can present as unexplained collapse. That's what usually happens, to be honest. So it's unexplained collapse. I don't know what's happened. The patient was very well before and then collapsed suddenly. And then severe abdominal pain or back pain, according to the site of the aneurysms. Typically intrascapular pain if it is something at the back, like the aortic aneurysm or dissecting aortic aneurysms. And sometimes it radiates to the groin. And if there is intra-abdominal bleeding, it can cause pain to the tip of the shoulder. This is something very important for surgeons and for obstetricians as well. Urinary tract symptoms and hematuria might be hiding an aneurysm history. Okay, it's a very famous question in the FRCS exams. Elderly male coming with flank pain. What's the working diagnosis? It's aneurysm, but now we're speaking about pregnant women. If a patient coming with unexplained collapse and there is some history of urinary tract symptoms, you should be worried actually, and you should keep in mind the history of ruptured aortic aneurysm is very serious because it's not only life-threatening, it's difficult to diagnose. Appendicitis, we spoke about appendicitis several times, gradual onset of colchibri umbilical pain, as I said before, and then become localized in the right iliac fossa. We usually say pain that shifts. Sometimes the appendix, the presentation is atypical. To be honest, it's not sometimes, that happens a lot, to be honest. It's uncommon to see a typical presentation of appendicitis, but we usually see the both things basically, because appendix can be anywhere. Sometimes it's retrocecal, sometimes it's pelvic. The site of the appendix change the presentation, so we have to bear in mind that this type of this lower abdominal pain or right-sided abdominal pain might be appendicitis. We should always consider appendicitis in these patients. And gravid uterus usually displays the appendix up, especially at the end of the pregnancy. And we spoke about the right upper quadrant pain and the dilemma: is it really acute appendicitis or just acute cholecystitis? Presentation may progress with appendiceal perforation, and that's why we usually see the patient, several times, and it's just active observation with these patients. And sometimes it progresses to cause generalized peritonitis or localized perforation, localized peritonitis. So we need to keep this in mind. I need to keep in mind that the diagnosis of acute appendicitis should always prompt surgical consultation and always consider an operation. It's frequently associated with nausea, vomiting, and anorexia. Usually, appendicitis patient vomit once or twice, but not persistent vomiting. But anorexia is very characteristic of appendicitis. It's not common at all if you ask patients with appendicitis, do you want to eat? And they will say, yes, I want to eat. Usually they are anorexic, okay, and nauseous. And usually they vomit once, not a lot. Other diagnoses, other conditions, I mean, biliary colics or acute cholecystitis is different. Biliary colic is different from acute cholecystitis. Biliary colic is just one stone stuck at the neck of the gallbladder, causing colics, and it's different, you know, inflammation, peritoneal irritation is different than just visceral pain. As gradual right upper quadrant pain or epigastric pain worsened by eating. It's not common, to be honest, but it's characteristic. If somebody eats something and then develop the pain, it's usually biliary colic. It's, yeah, it is characteristic, but it's not very common, to be honest. So it might last, as it's described here, minutes or hours, but it goes away by itself, the biliary colic. But the cholecystitis stays. It doesn't relieve by itself without active treatment like antibiotics and fluids and things like this. May radiate to the back, tenderness, and the right upper quadrant. So the tenderness usually indicate cholecystitis. The resistance of pain indicate cholecystitis, inflammation of the gallbladder. It's not just a stone stuck at the neck of the gallbladder. It is real inflammation of the gallbladder, and clinically we'll find some tenderness, which is increased with inspiration. When the patient take deep breath and bring the liver down, and you're putting the hand in the right upper quadrant, the patient just jump in a bit, you know, because the gallbladder comes down to your hand, so they don't continue the breathing, they stop breathing, they stop the inspiration. Okay, we call this Murphy's sign. And this suggestive of acute cholecystitis rather than biliary colics. Bowel obstruction, colicky pain, it is obstructed viscous, so colicky pain, nausea, vomiting, sometimes constipation, according to the site of the obstruction, to be honest. So if the obstruction is more proximal, start with vomiting, and then late constipation. If the obstruction is distal, they'll start with constipation and then vomiting. Small bowel obstruction, usually the vomiting is bilious, but sometimes it becomes feculent. But large bowel obstruction usually comes with abdominal distension, absolute constipation first before vomiting, and colicky abdominal pain. Vomiting may be feculent in both, to be honest, in large and small bowel obstruction, but commonly with large bowel obstruction, the vomiting becomes feculent. Clinical examination, no bowel sounds or early exaggerated bowel sounds, but that's not a common thing that we do in our real practice, to be honest. We don't auscultate the abdomen a lot because, you know, in early obstruction, it is hyperactive sounds, and late obstruction, it's absent bowel sounds. You know, it's very variable. So, but it's just something to know about the bowel obstruction. It might be absent the bowel sounds lately in the bowel obstruction. Pancreatitis, most commonly in pregnant ladies, we associated with gallstone disease, biliary colics or cholecystitis, usually sudden onset of upper abdominal pain. And we spoke about the differential diagnosis of the upper abdominal pain before. We'll speak about it again. Examination, upper abdominal tenderness, and this will depend on the severity of pancreatitis. We'll speak about severity of pancreatitis later in this presentation. Peptic ulcer disease, gradual, acute onset of retrosternal pain. If it is just peptic ulcer disease, if it is perforated, it will be something like, generalized peritonitis. Sometimes it can perforate retroperitoneally, but this will not present with generalized peritonitis and severe sepsis and things like this. If it is ruptured or perforated intraperitoneally, this will present with a full-blown picture of peritonitis. The patient will be guarding, and showing all the signs of peritoneal irritation. Urinary tract obstruction, like stones and things like this, usually it is colicky pain. That's characteristic of it, usually irradiating the loin or the groin. That's really characteristic of it. And it is associated with nausea and vomiting. To be honest, this is associated with vomiting more appendicitis. And in urine deb, you'll find some blood in the urine deb, in the urine analysis. So that's a quick, quick something through these abdominal surgical causes of acute abdominal pain in pregnancy. We'll speak about what to do with these patients. In the examination, we'll start with ABCDE as usual. Okay, so airway, breathing, circulation, disability, exposure. So you have to follow the ABCDE in all unwell patients. So give oxygen, give some fluids, give the saturation, and all these, baseline observation you do for these patients, and all the initial management of the ABCD as usual to deal with any acute respiratory, metabolic, or hemodynamic compromise during the initial presentation. We have to consider some pregnancy-specific physiological changes. We'll speak about them. And you have to perform a full abdominal examination, which, as we all know, have a inspection, palpation, percussion, auscultation, and digital rectal examination. And I will add, this is something that's not mentioned in this article, but I have to add it really, and it has to be considered, is to examine the sites of hernias. That's really, really, really important. I know it's not common to have a complicated hernia or a hernia that can cause bowel obstruction in pregnancy, but if you're going to speak to a surgeon, you have to do all these examination and to examine for hernias and or previous abdominal operations. So these are the very, very important two issues for surgical problems, basically, because they might be the cause of the acute abdominal pain, and they might be the cause of something like bowel obstruction. Pregnancy-specific consideration. You all know these physiological changes during pregnancy. Physiological changes and some anatomical changes really during pregnancy. You have to be aware about them because in pregnancy there are, new or other normal parameters for all these patients. So, total blood volume increased by 40%, cardiac output increase by 10 to 30%, rise increase in stroke volume, heart rate increase to 80 to 90, that's normal for pregnant women. Changes in respiratory system is less marked than the cardiovascular system, but still evident and still need to be considered. Metabolic rate increase oxygen consumption, basal body temperature a little bit increased, ventilation increased 40% by physiological hyperventilation. It is physiological in pregnant women. No change in vital capacity or rate. They breathe more deeply. Total volume increased from 500 to 700. So increase the respiratory capacity for them. More physiological changes because the blood volume increased 40%. So it's very difficult to assess for blood loss really in pregnant women. Okay, it's very difficult. And with some mild tachycardia, mild tachypnea, or narrow pulse pressure, or just agitation or an anxiety, you have to consider hypovolemic shock. These are really important, and what I wrote here in red is very, 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 very important. Fall in blood pressure is always a late sign. In any patient, to be honest, not just in pregnant women, but in pregnant women, it will be very late as well. Later than other patients because of this increase the circulating blood volume really. So don't depend on waiting for low blood pressure, or if the patient has a normal blood pressure, can still be bleeding, okay, and can still have hypovolemia, okay. That's really serious. Don't depend on blood pressure. The other thing which is not written here in this article, these patients, if somebody is bleeding, usually they have normal hemoglobin level, okay. I know there's some relative decrease in the hemoglobin in pregnancy and some physiological anemia or something like that, but don't depend on the hemoglobin level in settings of acute hemorrhage or acute bleeding. If somebody have 5 liters of blood, for example, or let's say 6 liters of blood with hemoglobin concentration of 15, and this pregnant lady bled 2 liters, the remaining 3 liters, the hemoglobin concentration is still the same. Okay, so in the lab we measure the hemoglobin concentration. Okay, so these are two very serious issues really with bleeding patients or bleeding pregnant ladies. Okay, don't depend or wait for low blood pressure, and don't depend on hemoglobin level. Okay, changes in hemoglobin level and all these things or blood pressure, they are late signs. Okay, you have to have low threshold of considering that this patient have hypovolemic shock. Okay, for all these reasons. Fetal heart auscultation or cardiotocography, depending on gestation, are really important. And we used to say usually when we give the when we used to give the lecture about the pregnant ladies in the ATLS course, the Advanced Trauma Life Support course, we have a dedicated section on lecture for pregnant ladies. We used to give this advice. So you monitor the mother via the fetus. It's very important to monitor the fetus, because you monitor what's happening to the mother via what is happening in the fetus, because the fetus will be affected very early and you will know what's happening to the mother from the fetus. But if you are concerned about the fetus, you have to be concerned about the mother first. So you usually resuscitate the fetus via the mother. So your main concern is the mother, but fetal monitoring is very important, not just for the fetus, but for the mother. Okay, so monitor mother via fetus and resuscitate fetus via mother. This sentence is not in this article, but this is from my experience and from other lectures and other courses, and and related mainly actually to trauma. So this slide is mainly about trauma or bleeding or something like the ruptured aneurysms where we spoke about. So don't wait for low blood pressure. I can't emphasize that more actually. Don't wait for low blood pressure and don't depend on hemoglobin. These are very common pitfalls that people have them as something in their practice really, unfortunately. Anatomical consideration is very famous image about the appendix which get pushed up with a gravid uterus. So gravid uterus can hide and make it difficult to examine for free fluid or hemoperineum in the abdominal cavity. So this can make it difficult really, and make it difficult as well to palpate abdominal masses. And change position of abdominal organ, as you can see here. I can push the appendix up, so it can present with right upper quadrant. So in right upper quadrant, in late pregnancy, You can see here 6 months, 5, 6, 7, 8 months here, right upper quadrant, you consider acute appendicitis as a differential diagnosis. Leading woman on her side, displaced uterus, and might help to differentiate uterine from extrauterine tenderness. So if the site of the maximum tenderness remained constant, when uterus moves, it's usually due to an extrauterine origin. Okay, so that's the trick. If you move the uterus and it's still the same, so probably it's extrauterine and it's not intrauterine pathology. You know, as we all know, rising level of obesity makes examination difficult. It's not just for pregnant ladies, for all population really. It's really a challenge. So we should have a low threshold for diagnostic. You know, more diagnostic investigations in these patients. Investigations in general in this category of patient can do some investigations bedside. We all know the Muse or News, the scores that we do here in the UK: pulse pressure, blood pressure, temperature, respiratory rate, and saturation. All these things. And what should be done, or actually must be done, it's very useful to get a urine dipstick. It's very useful. Sometimes it's not conclusive, but can exclude things, can include things in your differential diagnosis. So it's really useful and cheap as well to do it. The urine dipstick, it's a must. You have to do it. You have to ask for it. And it has to be documented clearly, the result of the urine dipstick. So mild glycosuria or some proteinuria are normal in pregnancy. You have to bear that in mind. If you've seen something, traces of something, usually it's not conclusive. So you do it usually with a strep breathing device. You just put a dipstick and have some reagent colors and just compare it with the color on the bottle or in the box, and you can have, you know, how much red blood cells, how many, how much is protein, how much is sugar, and all these things you can get from this dipstick. But here they're saying if 1+ or more protein, you should consider hypertensive disease of pregnancy. Okay, just for you to consider in these patients. Presence of leukocytes and nitrates are indicative of an infection. Yes, especially if there are a lot. A midstream urine specimen should be sent. We usually send it for culture as well. It's not just dipstick. We should send it for a culture. Something can be done bedside as well. We've discussed this before. ECG is important in pregnant women. I don't, you know, in general, in you know, in a woman which is not pregnant or a male young, we don't do ECG. But in women, pregnant women, we do ECG. Although it's rare, MI is rare in pregnancy, 6 in 100,000 delivery, but pregnancy still increase the risk 3-4 times of getting acute MI. And acute MI, as we discussed before, can present as acute upper abdominal pain. Okay, biochemical, we send a set of blood tests. To be honest, these are the routine blood tests we send for all the patients. Full blood count. So we need to be aware about the physiological anemia, as we spoke about it before. We need to be aware of moderate rise of leukocytes. So the upper limit here is 15. Normally, non-pregnant ladies, normally with just 11, I think, the upper limit. So in women, it's 15. It's really important to know these numbers because if it is 14, it's not raised, for example. Okay. Liver function tests are really important, especially if we're suspecting a biliary pathology, and we'll speak about this later. Urea and creatinine electrolytes. We need to bear in mind normal creat levels in pregnancy might indicate renal impairment because GFR increase in pregnancy anyway. Okay, So we need to bear these changes in mind. Amylase is a must in upper abdominal pain. It's a must. You have to ask for amylase in upper abdominal pain to exclude pancreatitis. CRP is very useful inflammatory marker. Usually, in non-pregnant ladies, it is less than 4. Here, it's the number in pregnant ladies 20. And we need to look in trends. If the patient is going to be admitted, you can repeat it after 12 hours or next day or something to look into trends. In surgery, we normally depend on CRP and white blood cells, so we repeat them every day, or if we need to follow trends and it's acute presentation, we can repeat them in 12 hours. We repeat both CRP and white blood cells. And to be honest, some papers saying is if the CRP and white blood cells are normal, you can say it's 90 to 95%. It's not, for example, acute appendicitis. It's very rare to have, it's not very rare, it's rare to have acute appendicitis with normal white blood cells and normal CRP. Okay, so these are, you know, the main 2 inflammatory markers we use in surgery in the UK, the CRP and white blood cells, and that's why these numbers are important to know, and it's important to look into the trends. ABG, yes, we asked for lactate for all acute, you know, all acute abdominal pain or all acute abdomens, or for all abdominal catastrophes. And lactate in this article saying lactate more than 4 can indicate sepsis or severe sepsis. Maybe in some other articles or other guidelines it's more than 2, but in this article they're quoting the number 4. Physiological hyperventilation results in higher PO2 level and lower PCO2, and compensatory falling bicarb. You have to bear this in mind when you do ABG. If the PO2 is, you know, is normal for non-pregnant lady, this patient might be hypoxic. Okay, because normally it's higher in pregnant women. Okay, so all these things are consideration during pregnancy. Okay, all these changes in number are really important in acute abdominal pain. Okay, imaging. Okay, a lot of debate here coming. Imaging. These are rules. You know, follow them with any patient, not just pregnant ladies. Imaging should not delay treatment in unstable patient. Okay, you don't wait for a CT scan, for example, for somebody who's very unwell and needs to go to theater. Okay, in general, not just pregnant lady. Decision should be with a senior surgeon. The advice with the senior surgeon, and balance risk versus benefit to mother and child, of course. Imaging findings should be interpreted with a you know, a senior radiologist and surgeon and obstetrician. What we do normally, we discuss with the obstetric team. So obstetric team discuss with me, for example, or for the surgical team. We decide, okay, we'll go for this imaging modality. We discuss it with the radiologist, and then get the scan done. And as soon as the scan done, we go to the radiologist, to the office of the radiologist, surgeon, obstetrician, and radiologist, and discuss the images together. Okay, so discuss the images and discuss, okay, what might be done, what are we seeing here, and that's what we usually do. What happens, okay, in gynecology and obstetric, in all cases really, but in obstetric, you know, and pregnant ladies should happen routinely. Okay, that's what happened. Plain chest X-ray is very, very important, especially in upper abdominal pain. You can get erect chest X-ray with shielding of the abdomen or the fetus. Okay, and it says low risk, and it should be erect. Okay, should be erect to look for air under the diaphragm, or even pneumonia. Okay, so these are the 2 very important things that we can identify from an erect chest X-ray air under the diaphragm that might indicate a perforation, which is very serious. And if you have a very unwell patient with proteinatic abdomen and get erect chest X-ray, sometimes it's very useful. I think it is sensitive about 60 to 70% for perforated viscous, so it can take decision quickly for an operation. Okay, so it's really valuable to get a directed chest X-ray. Estimated fatal dose per examination is 2 to 7 milligray, and doses up to 10 has negligible risk of developing a pregnancy in any trimester, carries increased risk of cancer about 0.002%. This is very negligible risk. So the chest X-ray, plain chest X-ray, especially with shielding, is safe and is very important and can show us under diaphragm or pneumonia. Okay, abdominal X-ray. Can I get abdominal X-ray? It's not written in details in this article, but it's not only harmful to the baby, okay, and increase the risk of radiation to the baby. It's not useful for surgeons. I don't usually myself ask for abdominal X-rays. It's not recommended in a lot of guidelines to get abdominal X-rays for surgical pathologies. Okay, it's not useful. Okay, it's CT scan or not actually. Okay, so bowel obstruction, you need to get a CT scan or MRI scan. You don't need to get an X-ray. Okay, we know there is abdominal distension. We know that. We know that I will find dilated bowel loops. Okay, so what can I do? Okay, so it's low yield, low diagnostic yield, these abdominal X-rays. So to get another CT or MRI scan, or just you're subjecting patient here to more radiation. You know what I mean? You do the abdominal X-ray and then you're going to ask for another modality for more accurate diagnosis. So you just subjected the patient to more radiation with no reason. Okay, ultrasound. Ultrasound is very important, very useful, and we use it a lot in ladies, pregnant or not pregnant, actually, especially for diagnosis of appendicitis. Not to diagnose appendicitis, but to exclude other causes. Okay, so here in pregnant ladies, you will almost always ask for ultrasound for viability of pregnancy, location of placenta, fibroid or ovarian pathology, and to have a look at the liver, gallbladder, bile ducts, and renal tract, and maybe for the appendix. But to be honest, it's not very reliable on a lot of centers because it can be visualized in just 60% of some of the case series, but some centers and some radiologists they might not see the appendix at all, and not seeing the appendix is not that doesn't mean that the patient doesn't have acute appendicitis. Okay, so and in the biggest series maybe they can say it's 60%, but don't depend on that. Don't depend on the ultrasound in diagnosing appendicitis, but depend on the ultrasound in excluding other causes of lower abdominal pain. Okay, but if they have seen the appendix and they've seen it inflamed, it's now specific to appendicitis. Okay, so these are the another study suggest 100% specificity. So if you can see big inflamed thickened appendix in the ultrasound, okay, fine, that's acute appendicitis if you can see it. But it depends on the center, it depends on the operator, it depends on a lot of things. But definitely if you can get it first, just get it. Okay, get the ultrasound. It's the first line, as they're saying here. It's a valuable first line imaging modality, especially in centers with MRI might not be readily available. Okay, so get ultrasound. Okay, yes, they might not see the appendix, but just get it. If they've seen the appendicitis, okay, you have a diagnosis. Okay, That's important for the fetus as well, and the placenta, other gynecological problems, liver and gallbladder. So it's important to exclude other things, okay? More than diagnosing the appendicitis. MRI versus CT scan. MRI is better, definitely, okay, because no associated risk of radiation, equivalent accuracy in non-traumatic pathologies, and the issue here is the ability to organize ultrasound. Okay, so MRI. So most of the hospitals, to be honest, have MRI scanner. Okay, but it's very, 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 very difficult to get an MRI done overnight. Okay, or after 5. Okay, so it's not practical to try to get MRI done after 5, but if it is during the daytime, starting from 8 in the morning till 5, you can, in most of the cases, arrange for MRI. Okay, and if the patient is very, most of the cases can wait. So if you've seen case midnight or 2 in the morning or something like that, and the patient is stable, you're suspecting appendicitis or cholecystitis or something like that, we think they need a scan, they can most of the time wait several hours. So patients most of the time can wait hours, but not days, okay? So most of the time, if they come during the day, you can organize MRI, that's fine. If they come overnight, you have to balance it, okay? And with discussion with the surgeon and the consultant and the radiologist and everybody, you can balance it. Can this patient wait till the morning to get an MRI scan, or the patient is very, very unwell, so get a CT scan, or just take the patient to theatre? Okay, so it's a matter of discussion. And with CT scan, to be honest, it's more sensitive and specific, and as they are writing here, it's the most sensitive and specific modality. Most of the time, it give you a definitive diagnosis. If it is appendicitis, it shows appendicitis, and if it didn't show appendicitis, it's not appendicitis. Okay, it's not inflamed. The appendix is not inflamed, for example. I mean, but here you're subjecting the fetus and the mother to a dose of radiation, which must be discussed. That's really, really, really important, and that's why I think these numbers here are really important for you, for your discussion with the mother and the family, and for the exam if you're going for an exam. Okay, so the dose of radiation exposed to the fetus is it is going to the pelvis 30 to 50 milligray, and we said it's 10 the maximum considered safe in previous slides. So we had here 10 should be negligible, but in the CT scan it's about 30 to 50. Okay, so there is risk, and we know the fetus most susceptible to teratogenic effect of ionizing radiation in the body. The organogenesis is about 5 to 15 weeks of gestation. Okay, and after that or before that, less susceptible. Even with these doses of radiation, the risk, to be honest, is still small. A risk of childhood cancer increased by 0.1% or 1 in 1,000. Fetal adult cancer 0.3%, which is 3 in 1,000. So 1 in 1,000 childhood cancer and 3 in 1,000 in adult cancer. Okay, and these should be discussed with mother. We don't normally need a CT scan unless the patient, it's the middle of the night, as I said before, and the patient unwell, and we need to get the diagnosis, or in trauma. Okay, so in surgical exams, MRCS, FRCS, or and surgical courses, trauma courses, it's a known question. If you have a pregnant lady and she's bleeding intra-abdominal, and what's the investigation of choice? It's a CT scan. What can you do? You need to save the mother. You need to know where is the bleeding, okay? Because we have other modalities we deal with abdominal with bleeding, intra-abdominal hemorrhage, other than laparotomies, okay, can be treated conservatively, sometimes interventional radiology, sometimes laparotomy. So you can, in life-threatening conditions, you can do a CT scan, but with a discussion with the patient and the family, okay? But most of the times, as I told you, the case can wait several hours, okay? It's ultrasound scan, which we do almost always for everyone, if it is appendix or query appendix or query cholecystitis or query other pathology, we do ultrasound scan, and then MRI if we're not sure, or it's bowel obstruction or other pathology. Okay, management, pain relief is very important. We don't like anti-inflammatory, non-steroidal inflammatory drugs for a lot of reasons, but we don't like them, and that's recommended in this article. We need to think about any further diagnostic tests in our MDT discussions or multidisciplinary discussion. We need to think about, is it early operative intervention or shall we wait for a period of observation? We all know that time is a very useful diagnostic tool. Time itself is a diagnostic tool. So if you comfortable patient is stable, you know, the fetus not threatened, you can wait and see the patient, you know, do active observation really. Anesthetic and medical consideration, acutely unwell patient should be optimized, of course, multidisciplinary input, and if you think that the patient might go to theater, involve the anesthetist very early, okay? That's really important. So the first thing, not the first thing, but very early when I see a patient that might need theater, I speak to the anesthetist because they assess the patients very well from the medical point of view and from the anesthetic point of view, okay? And they really help, and they pick up very important pieces from the history, and we as a team we act on it, okay? So you have an obstetrician, surgeon, and anesthetist dealing with the patient, so this is the best that this patient can get really. Obstetric consideration in the management. So they're recommending here that the obstetrician is the team leader in this case. Patient should be cared in a delivery suite or high dependence unit, especially in third trimester. These are two important numbers in your discussion with the patient. If the patient going to theater, there is a risk of miscarriage 7 in 1,000 and risk of preterm labor 3 in 100. Okay, so 7 in 1,000, 3 in 100. Know these numbers for yourself more than the exam. If you want to discuss with the patient risk of the operation, you say it's 7 in 1,000, okay, of miscarriage, and 3 in 100 preterm labor. Okay, so these are really two important numbers to know in your discussion with the patient. Patient must be fully informed, of course, benefit of procedure. Any woman undergoes surgery after 20 weeks, they should position left lateral tilt, of course, to minimize compression in inferior vena cava, and we do that in all pregnant ladies in trauma as well. Okay, to just shift the uterus to the other side, to the left side. Okay. 24 to 34 weeks, consider preoperative steroids if you have time. Fetal monitoring, important. As I said, we can monitor the mother via the fetus, and we can resuscitate the fetus via the mother. It's rarely necessary to deliver the fetus to treat the mother. It's not common. However, in late third trimester, consideration might be given to deliver prior to surgical intervention. Maybe if we're doing appendectomy, maybe in the late third trimester and the baby is okay and had some steroids, yes, we might considering delivering the baby before getting the appendix out. Okay. Yeah, that's what's written here. VTE, very important, heart assessment or VTE, venous thromboembolism, must not be forgotten, and it's always the hospital policies prevent this from happening, to be honest. So no patient is admitted to a ward without considering the hospital-acquired thrombosis risks and policy, and prescribing the anticoagulation for the patient, or prophylactic anticoagulation. Okay, if the operation will involve manipulation of uterus, we should consider anti-D according to the indication. Should be given rise as negative woman if fetus blood group is rise as positive or unknown. Okay. Surgical consideration, as we do always, synchronous assessment and resuscitation. The key decision here is to operate or not, a multidisciplinary approach as usual. Surgical conditions, I'm approaching to the end now. Just go quickly, very quickly, through the management of these different conditions and some numbers. Acute appendicitis is the most common acute surgical cause of abdominal pain in pregnancy. Most common surgical cause, I mean. 1 in 800 to 1,500 pregnancies. It happens. It happens mainly in the second trimester, but the risk of perforation is more in the third trimester. Okay, so it happens more in the second trimester, but the risk of perforation is more in the third trimester. Diagnosing acute appendicitis, urine analysis, yes, might be useful. You might find some leukocytes in the urine analysis. You might find even some red blood cells, okay, which makes a little bit confusing with ureteric stones. But if the appendix is touching the urinary bladder, you might have some leukocytes and red blood cells in the urine analysis. And that's why the urine analysis is not that conclusive, but you know, it's helpful. Biochemical tests, I mentioned the inflammatory markers, CRP and white blood cells are really important, especially if both are normal, and especially if repeated them after a few hours or a day and they are still normal. So that indicates it's very unlikely this is acute appendicitis. Okay, ultrasound, very, very useful. Okay, sometimes you might see a thickened appendix, sometimes you can see other pathologies or exclude other pathologies. So ultrasound is very important. It's operator dependent, as they said, sensitivity just 60 to 70, and some centers is less, much less than that. The specificity approaching 100% is about 83 to 93 because of that. If you've seen oblong thickened structure, it's likely to be appendix, so it's unlikely to get the diagnosis wrong if you've seen it. Clinical uncertainty, of course, get MRI scan, especially during the day hours. The appendicitis cases most of the time can wait hours, not days. That's what I usually tell my patients. So I usually tell them, if you have acute appendicitis, you can wait hours for an investigation, but or to get your operation done, I mean, but you cannot wait days. Okay, so they can wait till the next day if they came late in the morning, especially if they are relatively stable, or you can start stabilizing them. Then they have the scan. And the sensitivity 9 to 1, specificity 98. So it's a very good test, to be honest. Diagnostic laparoscopy can be done, but still it's an invasive procedure. Okay, and you can consider CT scans. CT scans not written here at all in these pathologies, but you can consider it if the patient really unwell, and you are in the middle of the night, and you know, in extreme circumstances, and you don't have MRI. Basically, if you have MRI, get MRI. You can always get ultrasound before, especially during the day hours. Ultrasound is very similar to MRI. Getting it, I mean, not the diagnostic yield. Getting ultrasound scan usually just during the day, not overnight. Okay, in the UK. They wrote here in this article that have been cited, the surgical condition required surgery. To be honest, in the last 2 years or maybe more, and especially with the COVID pandemic, this has been shifted a lot. Still, the mainstay management of acute appendicitis is surgery, but you can treat them conservatively. Okay, that's not written in this article, but in real life and in recent policies due to COVID, you can treat appendicitis, basically uncomplicated appendicitis medically with just antibiotics. Okay, but as an obstetrician, you should always consider that this required surgery and to leave this decision for the surgeon to take. Okay, so for you, it is a surgical condition, it is requiring surgery. Okay, but can it be treated conservative? Yes. Okay, but that's for us, for the surgeons to consider. Okay, but only the uncomplicated appendicitis can be treated medically. Okay, but the complicated appendicitis should be treated surgically. I mean, perforated appendicitis should be treated surgically. Operation can be done laparoscopic, dependent on a lot of things: severity, surgical expertise, and gestation. Most of the cases we do it laparoscopic. Very rarely we do it open, but every now and then we have an open case to do. The maternal and fetal morbidity and even mortality can just depend on the severity of the appendicitis. It is a progressive disease. Early diagnosis and treatment to prevent perforation or generalized peritonitis is important. It will progress. It will perforate at some point. But as I told you, yes, recently we're considering more, using more medical management, but that's not what is written here in this article. Chronic appendicitis, just wondered about chronic appendicitis, don't like the term, but anyway, appendiceal masses, the literature, the evidence is minimal in literature, so there's not a lot of evidence, but you can treat them conservatively. So you can treat the appendicitis conservatively if it's chronic or there is appendiceal mass. Biliary colic, okay, coming to the right upper quadrant now. Physiological change of pregnancy, some sort of cholestasis and some sort of cholesterol secretion and supersaturated bile can predispose to gallstones. Anyway, in general, I think something like 20 to 25% of all people have some sort of gallstones, but this can cause, but some of them symptomatic, some of them asymptomatic. We don't do anything for asymptomatic cases. If there's some symptomatic, we just deal with it surgically, basically, or consider surgery. Cholecystitis is the second most common abdominal surgical pathology in pregnancy. Okay, 1 to 6 cases in 1,000. Okay, numbers here again. Over 90% of the cases associated with gallstones. Yeah, sometimes we have acalcular cholecystitis, but we should always consider that the cause of cholecystitis is gallstones. We had to bear in mind, as I mentioned before, the appendix displaced with the gravid uterus up late in pregnancy. So in right upper quadrant, pain, tenderness, you have to consider appendicitis as differential diagnosis. Okay. As you see here, if you have gallstones, can stuck at the neck of the gallbladder here and cause biliary colic. If stuck for more, some time and cause stasis, can cause cholecystitis. So biliary colic different than cholecystitis. Cholecystitis inflammation, biliary colic is just spasms in the gallbladder. If the stone run here and stuck here, it will close the CBD or common bile duct. It can cause jaundice. It can cause inflammation. So obstructive jaundice and cause inflammation. We can call it cholangitis. It's different. It will be deranged LFTs. Cholecystitis is not associated normally with deranged LFTs. If the stone is stuck in the CBD, it will cause deranged LFTs because it will cause obstructive jaundice and raised inflammatory markers as well. Okay, so biliary colic, no raised inflammatory markers. Cholecystitis, raised inflammatory markers. Just obstructive jaundice, no raised inflammatory markers. cholangitis, raised inflammatory markers, and ranged LFTs. Sometimes when a stone come here and stuck here, it closes the pancreatic duct. It can cause pancreatitis as well. Okay, so the spectrum of the biliary conditions that can happen: biliary colic, cholecystitis, obstructive jaundice, cholangitis, and pancreatitis. Okay? There are more, but this is the spectrum of the things can happen from gallstone. Okay, the most common things basically. Biliary colic, cholecystitis, biliary colic. The biochemical tests will be normal. In cholecystitis will be deranged. The CRP will be raised. In biliary colics they will be normal. Liver function tests should be normal in biliary colic and cholecystitis, and should be abnormal if there is obstructive jaundice, if the stone stuck here, okay, or there is an inflammation here because of the stone stuck here, cholangitis or obstructive jaundice, okay. And this might indicate stone in CBD. We mentioned that. The ultrasound is the king here. It's very, very important in biliary issues, really. We even in non-pregnant lady, we rarely require a CT scan or other sort of imaging. The ultrasound is the modality of choice in biliary issues, okay? So in biliary colic, ultrasound; cholecystitis, ultrasound; in cholangitis or pancreatitis even, the first investigation of choice, even in non-pregnant ladies, is ultrasound, okay? Showed more than 95% sensitivity for detecting gallstones. So it's very, very valuable test. If in the ultrasound came back as we have gallstones, okay, is the CBD dilated? CBD is the cone bile duct, this one. If it is dilated, or there is deranged LFTs, that indicate there might be a stone here, okay? So we don't usually deal, we're not just dealing with a problem in the gallbladder, no, we're dealing with a problem in the cone bile duct, okay? So we need to consider clearing the cone bile duct before dealing with any problem or in the gallbladder, okay? So we, in these cases, they might need ERCP, which is endoscopic retrograde cholangiopancreatography. But before doing that, we do what we call MRCP, which is magnetic resonance cholangiopancreatography. We just magnetic scan to see if there is any stone or here or not or here, okay? Just a magnetic scan, just very easy, magnetic scan to see if there is a stone here or not. If there is a stone here, we'll go for ERCP, which is a scope test. We'll go here, 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 and put here, cannulate the CBD and just extract these stones or bot stents or whatever, just to get the stone out, okay? Because obstructive jaundice or cholangitis is relatively life-threatening problem. We don't do ERCP or MRCPs in biliary colic or cholecystitis or even pancreatitis. We do it if we have evidence of stone here, okay? And we can have evidence of stone in the CBD with ultrasound. Not common to see stones here. Common to see stones in the gallbladder rather than the CBD, okay? Because CBD usually is hiding beyond the duodenum and gases and things like this, so it's difficult to see with ultrasound, but sometimes you can see it, okay? But if it is dilated or the liver function test abnormal, we can get what we call the magnetic scan to see if there are stones here. If there is a stone here, we need to get the RCP, which is done under X-ray guidance, okay, and involve contrast and things like this, but it is considered safe during pregnancy, the ERCP and MRCP, okay? Again, biliary colic, just analgesia, antiemetics. Definitive laparoscopic cholecystectomy should be done, but we usually prefer to do it later, not during pregnancy. A lot of papers of doing cholecystectomy during pregnancy, but if the biliary colic resolves, just do it after. Acute cholecystitis, usually settle down with some IV antibiotics, analgesia, and IV antibiotics. Are writing here nil mouse. We don't usually do that. If the patient can tolerate eating and drinking, let the patient eat and drink. But that's the advice of this article. Nil mouse. And IV antibiotics, these settle most of the time, to be honest, okay? The acute cholecystitis, and that's why we do it um, after the pregnancy, really. We do the operation after the pregnancy if they settle. If they didn't settle and cause perforation or peritonitis, we have to deal with it, okay? Definitive surgery, definitely is preferable during the index admission in biliary cholecystitis. That we usually try to do that in all other patients, but we usually face some managerial difficulties and things like this to get these done during the same admission. We try to do that, but I think in pregnant ladies, um, you know, usually it's done, the operation done after the pregnancy, okay? And it is written, these difficulties in this article, it's not ignored, okay? So most of the cases in real life, you will do the operation after the pregnancy, okay? Bowel obstruction, okay, happened 1 in 1,500 pregnancy. It's as I told you, any bowel obstruction, you should consider, is it adhesional? Is it due to hernia? That's the two questions the surgeon will ask you when you refer the case. He will ask these two questions. Have you examined the hernial sites? Has this patient has any previous operation or not? So most commonly it's adhesional. Bowel displacement and distortion with gravid uterus maybe, you know, predisposed to this adhesional obstruction. Chronic pseudo obstruction can happen. Some people call it Ogilvy syndrome, and the colon. That's a functional problem, not a mechanical problem. Okay, it's not usually treated surgically. It's just treated with, you know, medications and enemas and laxatives and things like this. But in rare occasion, this pseudo obstruction can cause perforation. Okay, so and that's why you need at least to discuss with surgeon if you think it's just pseudo obstruction. Yes, it's not treated with surgery, but sometimes it can perforate. Okay, not common, but just to bear in mind. Biochemical tests in bowel obstruction can show just hypovolemic shock or what we call AKI, acute kidney injury, okay, due to dehydration. Abdominal X-ray, as I mentioned before, should be avoided. It's not, you know, potential harm to the fetus, and for us, for surgeons, it's really low diagnostic yield, so it's not that useful. Ultrasound, they've recommended in the article ultrasound and MRI considered safe, but you know, I don't think the ultrasound plays any role in diagnosing bowel obstruction. It's useless in bowel obstruction, but yes, you can get ultrasound for other purposes like the fetus, placenta, fibroid, other things, but for bowel obstruction, it's not used at all. MRI should be okay. Initial treatment is conservative. You know, I think 60% of cases of adhesive bowel obstruction, or maybe more, can resolve just with conservative management, intravenous fluid, nasogastric tube insertion, and Nelby mouth. Here, Nelby mouth is important. Okay, so these cases resolve conservatively, especially if they are adhesive bowel obstruction. If the cause is something else, like volvulus, tumor, which is rare in pregnancy but can happen. If it is hernia, it's not going to resolve conservatively. Okay, if it's just adhesional, can resolve conservatively. If the cause is mechanical, like hernias or something like, you know, different, it's not going to resolve. Okay, it needs an operation. Okay, and that's why CT scan or MRI are really important. MRI here in this occasion, in these cases. Is it large or small bowel obstruction? But we need to bear in mind that even adhesional bowel obstruction can be complicated with ischemia and perforation, and that's why these patients need to be seen by surgeon. We assess for ischemia and perforation radiologically and clinically and biochemically. Okay, so examine the patient. If the patient showed signs of peritoneal irritation, or the patient is not progressing, or the clinical deterioration or something that indicate ischemia or perforation that's serious, okay, and needs surgical intervention. And that's why they're suggesting early senior surgical consultation, okay, because they can progress to perforation ischemia. Pancreatitis happens 3 in 10,000 pregnancy. Pancreatitis in non-pregnant ladies 80% of the time caused by gallstones or alcohol, but in pregnant ladies, as you see here, 70% caused by biliary problem. As I mentioned before in this image, if the stone come here and stuck here, can cause pancreatitis. Okay. Where is it? Yeah, pancreatitis. Initial treatment is conservative. It's very, 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 very rarely that we need to intervene surgically in a pancreatitis patient. Okay, but we can do some interventions accordingly if we have evidence of a stone in a CBD, as I mentioned before, we can do an ERCP, endoscopic retrograde cholangiopancreatography, okay, and take the stone out or put stents. Diagnosis, we always say it's 2 out of 3, but here in pregnant ladies there are 2 because the third one is a CT scan. We don't do a CT scan so often in the pregnant ladies, but if you have pain and serum amylase more than 3 folds of normal, that's diagnostic of pancreatitis. Okay. Serum lipase is more sensitive and specific, of course. If it is present, just do it, because amylase, levels goes down from the start of the pain. Okay, so lipase is more specific, but amylase more than 3 folds of normal should be diagnostic with a specific upper abdominal pain. Severe pancreatitis should be managed in specialized units. Yes, of course, you might need more interventions, or it's very, very, very rare nowadays that we do these things, or specialized pancreatic units do these things like necrosectomy and these things, but you just discuss it to HPB surgeon or something. Okay. Ureteric obstruction, very important in diagnosis. There are some people who are stone formers, so you need to ask about history of renal calculi. Complication usually hydronephrosis and bionephritis, but you need to bear in mind that in pregnancy there are some mild renal hydronephrosis anyway. It's normal in pregnancy, so pelvic LCL diameter is 5 millimeters on the left side or 15 millimeters on the right side, considered normal, and up to 2 centimeters in third trimester in the ureters. Okay, these numbers considered normal in pregnancy. It's pain in the flank, as I discussed before in the picture of the sites of the abdominal pain. Unit analysis will show leukocytes and some microscopic hematuria, and I told you the diagnostic dilemma. Sometimes the appendix got touching the urinary bladder, and you will have leukocytes and microscopic hematuria as well. But anyway, biochemical tests, EGFR, important renal function tests. I mean, sepsis, renal impairment, these things are really important. So this is the ureteric obstruction. Ultrasound, very, very useful. Get MRI if you can next day or the same day. Next day if the patient came overnight. Bionephritis should be admitted for IV antibiotics, of course. Bionephritis treated with fluids and antibiotics. Surgery is indicated if there is deterioration despite of treatment, or very unwell patient with abscesses, emphysematous bionephritis, or obstructing calculus. Okay, and the management can be with stenting, it's just put a stent, or percutaneous nephrostomy. And urologists can do stenting. Percutaneous nephrostomy can be done with the interventional radiologist can do it for you. And you should always discuss with radiology early, a senior radiologist, urologist. Ruptured visceral artery aneurysm, very serious, as I mentioned. Although it's rare, the risk increases with pregnancy. I don't know why, but it is rare, but the risk is higher in pregnancy. Okay. Priority in management is diagnosis, which is really difficult. But there is a concept nowadays of balanced or minimum resuscitation to achieve what we call permissive hypotension. So you don't need to resuscitate the patient with blood products or fluids to get to normal blood pressure. Okay, you know, to get to normal conscious level and urine output. Okay, so that's a good perfusion, although the patient might have low blood pressure, okay, around 90s or 80s or whatever, but as long as the patient has good conscious level, the brain is perfused well and the kidney is perfused well, okay, that will give you the permission, okay, to let the patient be hypotensive. And that's what we call it, permissive hypotensive. That's the concept of permissive hypotension. Okay. A prompt consultation with vascular surgeon, definitely important. And probably in these cases, you're probably very unwell patient, sudden collapse. Yes, she's pregnant, but if you are middle of the night, you might get a CT scan in these cases. Okay, there's a window of opportunity for successful emergency repair, and they prefer here an open repair. In this article, they prefer open repair versus radiological repair. This can be done endovascular repair, of course. Anything vascular, you know, most of the things vascular stuff can be done endovascular repair, but they prefer open repair here in these cases, just to minimize the risk of exposure to radiation. Half of all arterial aneurysm rupture in women of childbearing age are associated with pregnancy, unfortunately. That's what they found. Splenic artery aneurysm is famous because it's the most common type of visceral artery aneurysm. Up to 25 cases present during pregnancy associated with high maternal and fetal mortality. It's a fatal thing, okay? 95 cases, that's a lot. So you have to bear it in mind in sudden collapse, if sudden collapse happens in pregnant women. The difficulties, again, it's unpredictable and sometimes unavoidable, but we need to take prompt, rigorous action because survival is occasionally possible. Okay, so in summary, we have discussed today the differential diagnosis of acute surgical causes or surgical causes of acute abdominal pain in pregnancy. We've discussed how to take history and examine these patients and what investigations of choice and what's the usefulness of these investigations. And we spoke about specific adaptation and consideration during pregnancy, physiological changes, anatomical changes, all these things, and how collaborative multidisciplinary practice is really essential and important in dealing with these patients.